Yeah, Dr. Pulshan has explained very nicely how to score a basic polysomnography recording. I will be taking you something, few aspect of some difficulties when you face in scoring in some certain conditions. Just little above what Dr. Pulshan told. Like always, sometimes it may not be so easy to identify. Like it is polysomnography scoring is very easy. Like if you identify K complex and sleep spindles, they are a definite of end to stage. And then if you find a rapid eye movement, and then mixed frequency activities and low EMG, there will be definite of REM sleep. Certain situation you may not find all this kind of clear picture, like to say it is a clear REM sleep, clear end to sleep. So N3 we don't have much difficulty. We can say clearly most of the times. So what kind of situations we get this kind of challenges? Like we just focus on the some problem related to current ASM guidance. Okay. So like scoring, like just I will give some brief introduction, like uh, how the, like what is the basic requirement, how the waveforms are generated, like and then like what kind of happens in certain conditions, like particularly neurodegenerative disorders. So EEG is like a recording of spontaneous electric activities which is generated by cerebral neurons. And then these are action potential in the excitatory inhibitory polysynaptic system. An action potential in the excitatory and inhibitory presynaptic fiber induce excitatory postsynaptic potential and inhibitory postsynaptic potential. These potential have amplitude and synaptic potential have a longer duration, and then they overlap, and then they will generate a longer. They will have a larger membrane, so they will have a visible electrical activities for the when we record it from the scalp. Though all summation of these electrical activities will look as a large potential when you record the EEG activities. EEG activities, like because the surface is negative and then inside a deeper is a positive, can create a dipole, the electrical activity, then so that we can record from the scalp electrodes. So based on these electrical activities from the cerebral cortex, like we have different kinds of cerebral activities, like delta, theta, and alpha, beta. So to generate this kind of electric activity, there should be a like switching mechanisms, when to generate, when is going to having a delta activities, when is going to have a theta activities, when is going to have a beta fast activities. So this switching happens by apart from the cortical, this is thalamic, predominantly in the thalamic inhibitory neurons, thalamic reticular neurons, and brainstem cholinergic neurons, or different parts of the brain also will take part in the generation of this kind of electric activity, which we record from the scalp. So like first we have to understand, like so what I'm going to talk on neurodegenerative disorders. Like certain brain areas are going to degenerate. It means there is a loss of cells. So how it is going to affect? For that, like I want to tell about you how the K complexes are generated. How the K complexes are generated. Like for that, we have some studies done before. So if you see in the functional MRI, when the time lock to K complexes, this is like functional MRI studies where the K complexes are shown to have been like bilateral thalamus is hyperactive, posterior cingulate is hyperactive, and then this is a bilateral thalamus, posterior cingulate, and then supramarginal temporal supramarginal gyrus, and all these are activated during the K complexes, and then during the sleep spindles. This is for the K complex. K complex also similarly, that much wider areas are activated when the functional MRI is done when it's time blocked to K complexes, like including bilateral thalamus, bilateral supramarginal gyrus, and as well as brainstem regions also involved. Okay. So like I want to tell you about again regarding the rapid eye movement. When the rapid eye movements are going to generate. If you do a functional MRI, when it is time locked to occurrence of rapid eye movement, there is a involvement of contact tegmentum, ventroposterior thalamus, posterior visual cortex, putamen, limbic areas, which are activated associated with rapid eye movements. These are the pontine tegmentum region which is involved, and then as well as bilateral thalamus also involved, and then bilateral parahippocampal gyrus also involved. So like it is just like a which areas are active. Like we cannot clearly say that these are going to generate, but we can just roughly have an idea like where are the areas are active. This thing like what is the neurodegeneration? What is going to happen in kind of neurodegeneration? Neurodegeneration, we have a lot of disorders. Like you don't get confused like how many disorders are there. Like but you just see this part of the main anatomical structures where the degeneration happening in each kind of disease. If you are not like a neurologist, you may difficult to remember all these kinds of diseases. But just you have a researcher and basic scientist or a technician, like just have an idea, look up what kind of these disorder have a what pattern of anatomical degenerations. So like some people have a predictions of some particular brain thalamus, cerebellum, cerebellar cortex, and then forebrain, limbic structures, olfactory bulb, like a frontal lobe, and subthalamic nucleus in PSP, subthalamic nuclei. Thalamus is involved, some of them, and then there is a brainstem also involved in some of them, and cerebellum delta nucleus also involved in some of them. So like multiple system atrophy, you have a seen pontine nucleus. There is where the REM sleep generators centers are there, and then cerebellum is involved, and then so like we are going to tell about in more of spinocerebellar ataxia, where we have done a lot of studies in these patients, like what has happened predominantly, what kind of structures are degenerated. These whatever diseases I showed you. These are progressive degenerative disorders, like the cells will brain cells, neuronal brain cells, slowly disintegrate, slowly die in over a period of length of time, so maybe in 10, 20 years, like that. It depends on the disease condition. Something maybe in 30 years, like that. Slowly they will degenerate. So in the cerebral ataxia disorders of patients, predominantly this is cerebellum. This is a normal patient. Cerebellum is become a much smaller, and then this is a brainstem also involved. Brainstem also they'll have a degeneration. See, we have all pathological studies clearly delineating where particularly this kind of degeneration happens in the which structures are degenerated in these disorders. Like if you see that pathological pictures, this is the control patients. There is a pontine degeneration significant is there. Bilateral. This, if you see that schematic diagrams where the areas are degenerated, like we have a common in Indian scenario is SCA1, SCA2, SCA3 type of patients. In these disorders we see, in these common disorders we find like how the intensity of degeneration is happen. There is cerebellum, pons in midbrain as well as in the thalamus, which diseases involve like prediction red. This intensity of red indicates the intensity of degeneration involved. So like by seeing this, we also in these patients, what is going to happen to the K complex? What is going to happen to the rapid eye movement? That is the scenario. So like we have a like this science is well advanced. Like we have a pathological studies also there. How much amount of degeneration in each areas of each nucleus in the like in thalamus, basal ganglia, in spinocerebellar ataxia 1, 2, 3, we have. These are similar. And next is like we have done this study in these patients. Like we just measure like how many sleep spindles in these patients will have in SCA1, 2, 3 patients. like, but we have done in a very small number of patients, like maybe in 5, 6, 7 patients each group. Maybe in one is like in the each group we have 5, 6, 7 patients. So like SCA1, SCA2 patients, we have almost hardly didn't have any sleep spindles. SCA2 is little amount, SCA1 is little good amount. This also depends on like how much severity of illness. It's a more severe form of illness we not find in. Maybe in SCA2 patients have a severe form of illness. We didn't find any sleep spindles in this patient, but control have a significant amount of sleep spindles. So like after we did like some other studies also come up after that, like in SCA2 patients, either in sometimes in the preclinical careers also have a decreased sleep spindle density as compared to healthy controls. And then there is also in regarding K complexes also there is a decreased amount of sleep spindle K complexes in preclinical careers as well as in patients and compared to healthy controls. So what will happen, like if you see this nice graph, like what Dr. Bhushan has explained you very well, you find nice sleep spindles and nice K complex. You tell it is directly, it is, we don't have any confusion over that, like any beginner or just learner who had identified once or twice or 10 times, then he can identify the this is N2 stage. But we do some these studies in these patients, like we have a little confusion, like whether it is there is the sleep spindle, you have to search it, and then like this is a low EMG, there is a phasic REM also EEG. This kind of situation like largely depends on when to continue your N2 stage, and then when to continue your REM sleep, and then it largely depends on a previous epoch. So like if it is no, you won't find an entire record of good number of sleep spindles. Like you find somewhere in one sleep spindle that will change the complete picture of your scoring record, whether it is more favoring of N2 or more favoring of REM sleep. So like we should be very careful in searching like where is sleep spindle, where is this thing. Particularly if the people are not generating sleep spindles or K compresses good number for you to recognize. So you're like you for like so like you have to be very careful in going through this recording twice, thrice. You have to check before turning going on to each patient whether the sleep spindle is there or not. So we have done another like this similar challenges we explained in detail in one paper. Like this additionally, like because of pontine degeneration, these people, these spinocerebellar ataxia patients also have a oculomotor dysfunction. So like what we demonstrated, like rapid eye movements which occurs in the sleep, or which are rapid eye movement in the sleep, or both are related. If you find the decreased eye movement during the awake state, when you examine when the patient is awake, and then eye movement velocity is decreased. Then similarly, we find like this patient may not able to put a good amount of rapid movements in the sleep. Then you have a little small lot of difficulty in identifying the REM sleep stage in these patients. So like this is a token means like this is severity of eye movement velocity. We find is uh, uh, high movement velocity degree of impairment. If it is 8 is the maximum degree. If it is less involvement, you have good amount of REM sleep recognition. You can able to recognize a good amount of REM sleep. So this is a patient where we had like this is ICAS is 12 means like he has a severe, not like very limited amount of disease, like he has early phase of disease. So this patient could able to generate good amount of rapid eye movements. You can note that this some rapid eye movements are like this is also rapid eye movement. There are a smaller amplitude. These are a bigger amplitudes. There is a mixed frequency activities, low EMG, phasic EMG. Then you can say like clearly this patient have a REM sleep. Certain like if you take an example where thalamic degeneration much higher in uh, other patients like SA2, this ICARS is 52 means like this disease is like this is a 100 score, you can use 52% disease, which is maximum almost like so like he has more of degeneration. This person is not able to generate no sleep spindles. You may not able to you such the entire recording, like you may not I could not able to find any rapid eye movements. And this kind of activity we can find, and phasic EMG we find. sometimes it will be very difficult to score it as a REM sleep, because we should not, as per the rules, you have to demonstrate rapid eye movements. So if you are not able to, patient is not able to generate rapid eye movements, and then you cannot score it as a definite REM stage. Then if you are able to generate score as a definite REM stage, you can like continues to score as REM stage until it is appearance of other stage like sleep spindles, Kicker complex, and then these patients are not able to either generate sometimes in the sleep spindles. It will be very difficult. Like he may have some few sleep spindles, so this entire epoch is, by default it goes into the N2 stage. So this another recording, like this is the small which entire record. This patient have a good similar form of illness also there, but he had a entire, for the entire recording I could have only found out this only one rapid eye movement. This is a very small amplitude. Like if you miss this kind of rapid eye movements in these patients, you say like you have to, by default you have to score it as a previous epoch. If the previous epoch shows something like a sleeve spindles and then K complex, then you score it as N2 stage. And then like if you don't see this rapid if you miss this, then you'll be scoring as a REM sleep 0 in these patients. So if you enlarge, if I reduce the frequency like the sensitivity to 50 microvolts, so it is appearing little bigger. Usually you have to put it in 125 in microvolt sensitive and scoring a rapid EOGs. This is another recording, like other phasic events are there, but we may not able to find any rapid eye movements. Or this also is difficult kind of. It all depends on the previous epoch, what happened in the previous epoch. Like if it is K complex are there, we can score it as N2. If it is somewhere in the rapid eye movements are there, we can score it as a stage or REM sleep. Okay, so like so I'm concluding now. Like if it is like a scoring of sleep space in the neurodegenerative disorders requires very special attention. Like because these people generate very poor sleep spindles and then K complexes generation and rapid eye movement generation. So like which we told some previous papers, like they require some little modification, and particularly when you are dealing with neurodegenerative disorders patients. Like but it is challenging, like how to create different characteristics, some modifications. So now I'm concluding my talk, and then any questions I'll happy to take.